All right, everybody, this is Dr. K from the Black Hills Regional Eye Institute, and we've got kind of an interesting case today. This is a case of a patient with a Kamra inlay. Now, some of these patients with these inlays, they'll have some haze that requires the inlays to be removed, open up the pocket, pull out the inlay because there's too much haze. But actually, this patient did fairly well with his inlay and did not have a lot of haze, so we decided to just do cataract case with the inlay in place. So make our side port. You can see here probably it's that diamond might not be, or it could be a little sharper maybe, or maybe the angle wasn't just right. But a little bit of counter traction to get that side port in there. And then we're using, this is BSS with omidria to try and expand the pupil. I find that is almost as good as like a Fenlido because the pupil is kind of mid-dilated. And with that inlay in place and the mid-dilated pupil, it just makes visualization that much more difficult. This is a little bit of lidocaine, and then we'll get our viscoelastic in. And we'll see how big we can get that pupil. At the very least, we're trying to want to get it a little more stable and get a little more visibility. Because it is, with that inlay in there, it is more difficult to see for sure. It's probably more difficult than I anticipated. I'm pretty familiar with doing cases with corneal scarring, things like that. But as you can see, there's the inlay and there's the corneal marker. The pupil is just not that large, 5 to 6 millimeters. We're going to make our main incision, and with an iris that's not as expanded as you'd like, you kind of want to make a longer incision so that there's less risk of the iris prolapsing through the wound. So we'll take our time here making this incision. There you go, and that's a good length. You just don't want a short incision where the iris is going to have the tendency to come to the wound. So now we've got our side port, we've got our main incision, viscoelastic is in. Let's see about creating our capsular excess. And we want to get it as big as possible, and you can see that you try to just hide behind that inlay. The inlay is perforated, but you cannot really see through it very easily. It's a bunch of little pinholes for the main purpose of allowing, I think, kind of nutrients and fluid flow through the stroma. So we will expand, and I kind of felt like the rhexis was just tending to want to go out under the iris here, so I want to bring it back in, re-grasp a couple times, do it carefully. With visualization reduced, I kind of felt like I didn't have a good sense of exactly the tension forces on the rhexis. Now we'll do our hydrodissection, hydrodelineation. Let's see if we can get that fluid wave. There was kind of one. Let's see if we get another one. Yeah, not really. Just 1 to 1.5. Let's see here. Let's see if we can get that to spin. The main thing is get that lens to spin, and that first fluid wave might have done it for us. There we go. Now we got a little mobility. And try and get some hydrodelineation as well, because if we can get the main bulk of the nucleus out, then we will be able to get the epinucleus out. We could express it. We could use IA. There's a lot of options. Now we're going to use phaco. So we're going to check our incisions. We refilled the viscoelastic. Now we're going to see what can we see. Let's clear the anterior epinucleus and cortical material and visco on high vacuum. Then we're going to go to sculpt. Let's see what we get. Really, the only view we get of our trench is straight through that central hole of the Kamra inlay. And you can angle the eye and get a better view, but I just want to make sure I'm going deep enough but not too deep. And really that inlay blocks some of the cues that you might use to judge depth. This is the length of the sidewall. It's just harder to see. Okay, but I think I'm deep enough. We'll see if we can get a crack. We're going to look on the outside. There's a crack. Perfect. That's excellent. And now let's try and chop. See what we get there. Oh, that's a decent chop. So notice we didn't even rotate. We just put the chopper out over the edge of the nuclear material, pulled it in and was able to chop that quadrant. I do use that technique, chopping right after the trench in lenses that don't rotate. Sometimes you can pull up a whole heminucleus. And here in this situation, I think it was just the lack of comfort of manipulating in an area you can't really see. Just stick with what you can see. Now we're going to reinflate with viscoelastic. Why? Because most of the phaco that I'm doing is in the anterior chamber. It's a little more anterior than I typically like to be, but I feel like my view is so much better up there because that inlay is in the way. So now, chop that second heminucleus and bring it up a little bit. There's a little more space now. Get it right in the center of that Kamra inlay so we can see what's going on. And we'll just see what we can bring forward. You can see you don't want to go fishing for these pieces, and right where that edge of the piece is right over or under where that inlay is. So we're trying to get that last quadrant out. There we go. There's a couple of pieces floating around there. Got that. Now we've got the epinucleus coming out. Most of it. There we go. And let's see if we can rotate this. If it doesn't rotate, there's a piece that comes out. If it does rotate, I'm probably going to go with the IA because I don't want to be fishing with the phaco, with the pad visability. That's not the best technique. All right, so majority of the lens is out. There's still some epinucleus that's subincisional and also some cortical material. But we're going to switch to IA because of the safety to try and get the last remaining pieces out. Getting epinucleus out with IA is just, you have to have patience. It takes a lot longer. It seems a little frustrating. Sometimes it doesn't want to come. But if you're patient, it will work. And if it's subincisional and it's really stuck, then usually it's safer. You could try irrigating with some BSS from the side port to try and kind of power wash it off. That would be a reasonable technique as well to liberate some of that subincisional epinucleus and cortical material, but this seemed to work just fine. See what we got. There we go. Nice sweeping motion. I feel like that helps prevent, that sweeping helps prevent grabbing just capsule. Now we'll do our power wash with the BSS. Make sure there's no cap or cortical material in the fornix. CDE is relatively low, which is good. But we got the whole lens out, which is what we wanted. The remainder of this case should be fairly straightforward. We'll get our Provisc in. There we go. We'll do a little sweeping and polishing with the capsule. When I can't see where I'm sweeping, I'm usually not too aggressive because not only can you not tell how much lens material you're getting off, but you're probably liberating some pigment from the iris. So you don't want to do that too much. Let's get our lens in here. There we go. See about folding that haptic back around. Awesome. Check and make sure that that's in the bag. Use our sense key to position that trailing haptic. Let's see, what if we check distally? There we go. Check distally, make sure that's under. Okay, now we'll get our IA out. We'll go behind the lens. We'll get out all of our Provisc. Back there, there we go. Center it, sweep the angle as much as possible. And then just hydrate our incisions. This patient was aimed for, a little myopic result in order to keep the functionality of that camera inlay. So maybe minus 75 or so. The pinhole will improve the distance vision, and it will allow a minus 75 to have, higher than expected near vision. And you can see the microscope lights are centered right in the center of that camera inlay, even though the inlay maybe doesn't look centered to the pupil. We've got some LRIs there, but even though the inlay doesn't look centered to the cornea, it is centered on the visual axis. That's one of the important checks you have to do when you insert those inlays. So we'll check our incisions, make sure everything's sealed up, and that's our case. So that went really well. The visibility was less, visualization was less than I expected, but fortunately everything went smoothly. All right, you folks have a great day.